Good evening, everybody. We are going to walk through a quick review of the face-to-face encounter requirements by CMS. Want to start with just kind of reviewing that CMS requires that there be documentation of a face-to-face encounter for any patient that you are billing Medicare for those home health services. Now, although they say in their rulings that it is not a requirement for Medicare Advantage plans, you do need to carefully review your contracts for each of those insurance companies, as most of them have the same requirements as traditional Medicare, and will still require that face-to-face encounter. In addition, just in 2017, the Medicaid services now require a face-to-face encounter. So the only ones going forward that I am aware of currently that do not require it is the VA. So your Veterans Administration does not require a face-to-face encounter, and most of your private insurance or your commercial insurance companies do not. But traditional Medicare is required, and I would go forward saying that the majority of your Medicare Advantage plans are also going to require documentation of a face-to-face encounter. Now, I provided everybody, hopefully you got the handouts that were included with this webinar. Some of those we'll look at today. Some of them are just for review or to have on hand for future reference. So make sure that you got all of those that are listed here on this slide. So just a quick review of what is required as far as the certification of a patient for home health. So the reason that CMS put this into place as far as the face-to-face requirement is to ensure that the physician that's ordering your home health services has current knowledge of that patient's current condition. So they want to make sure that the orders being provided by that physician are based off of the patient's current status, current conditions, current concerns, and so by ensuring that that physician has actually seen that patient face to face, they feel more comfortable and confident that the physician is making sound judgment when it comes to the orders they're providing. So when we say that a physician is certifying a patient for home health, basically what this means is that they are verifying that the patient meets all of the eligibility requirements for the home health benefit. They are also verifying that an allowed physician or an allowed non-physician practitioner has had a face-to-face encounter visit with that patient. Now, the time frame for this is very specific, so make sure if there's anything you take away that you take away these dates. That encounter has to be no more than 90 days prior or 30 days after the start of home health care. So 90 days prior or 30 days after. Now, one of the situations that they specifically talk about here within the CMS regulation has to do with new conditions that were not evident during a certain visit. So just real quickly going to review that here. If I'm going to give you a scenario here, if a physician sees a patient, say 60 days ago, and they see them for just their routine annual exam, they do labs, they check on all their chronic conditions, everything is stable. 30 days later, the patient falls and gets a skin tear, and that physician orders home health services for wound care. That visit that that physician had that 30 days prior has nothing to do with the wound. There is no mention, there is no observation, there's no assessment of that wound. This is a new condition that was not evident during that last visit. So what that means is that that patient now has to get in to see that physician within 30 days after admission for the reason that they're seeing that the patient has been on home health services. So the patient would need to go in and see that physician or that non-physician practitioner within 30 days for observation and assessment and documentation of that new wound. So keep that in mind if you are getting orders for a new condition that the patient has not been seen for. So who can perform the face-to-face encounter? Obviously, the following physician can. Now, there's a lot of confusion and misuse of the word certifying physician. Certifying physician means they're certifying that patient for home health. That is the physician that is signing your plan of care. Okay, a lot of times that gets confused with the physician that has done the face-to-face visit because they can be different. So when we talk about this, it can either be your certifying physician, which is your following physician, or it can be a physician that saw that patient in an acute or a post-acute care setting. So either one of these has to be, a visit has to have been completed with either following physician or in an inpatient facility. So if you're looking at this from your certifying physician stance, that's an MD, a DO, or a podiatrist. But in addition, the nurse practitioner, clinical nurse specialist, PA, or a certified nurse midwife can be the one that performs that actual visit if they are working alongside that certifying physician. Same goes with an acute or a post-acute care setting. So if your patient is coming to home health directly from that inpatient setting, you can utilize a visit from one of those providers as your face-to-face encounter. Again, it can be a physician, nurse practitioner, or a PA, but that person has to have cared for the patient in an acute or a post-acute care facility for which the patient is directly admitted to home health. Those are the only two types of physicians or practitioners that can do your face-to-face visit. Now, a lot of times we see referral orders come over from specialists. This is something you have to be very cautious of and aware of. Another scenario here for you. You have orders from a wound care physician to treat a pressure ulcer. They send over your wound care orders. They send over the order for skilled nurse to evaluate and treat for this wound. You go out, you do your visit, come to find out that patient has not seen their primary physician in 6 months. And that wound care doctor is not willing to sign your plan of care. They'll follow your wound care and they'll give you your wound care orders, but they are not willing to take responsibility and oversight of all of the patient issues. Because when you take on a patient for home health and you certify them for home health, you're following their medications. You're the person or the physician that gets called for any complications, new questions. So most of your specialists just are not going to take that step. What they're going to do is they're going to give you the wound care orders, but they're going to say that the PCP will be the one to sign your plan of care. Okay, so what that means is that specialist then cannot be the one to provide you with a face-to-face encounter visit. Because you can see here, remember this slide, there's only two ways or two providers that can do your face-to-face encounter. Either that patient has come from an inpatient facility and it is done by an acute or a post-acute care provider, or that visit has to be done by your following physician. So make sure when you get those orders coming through, they're getting referrals from certain specialists. Make sure that you know if that patient has been seen by the following physician and if that physician has seen the patient for the reason the patient is coming on to home health services. All right, so what kind of documentation meets the face-to-face? All right, so it's a two-part scenario. Number one, you have to have your visit note. So your actual clinical note, again, has to be from one of those allowed providers, has to have occurred within the required time frame, the 90 days prior, 30 days after, and it has to be related to the primary reason the patient requires home health services. So when you're verifying that you have a validated face-to-face encounter, you also have to know what you're putting the patient on service for. So you have to have some sort of idea of why this patient is being referred to home health services. And what I mean by that is, say, let's take our wound care example. The patient's coming on to service for wound care, but the actual clinical note we have is from the PCP and it's related to COPD. Those don't mesh. They have to match. They have to, your encounter visit note has to be related to the primary reason for home health services. So first and foremost, as far as documenting your face-to-face, you have to have the actual clinical note. That actual clinical note also has to prove that it was a true face-to-face encounter. There has to be some sort of objective assessment to show that that physician saw that patient face-to-face. So some sort of objective assessment. The second part of meeting this and the second part of the required documentation is that the following physician, whoever is signing your plan and care, has to document the date that the encounter occurred. They have to document the patient's homebound status, and they have to document the need for skilled services. So what that means is it's a two-part scenario. And the reason I say it's two-part is because most of your clinical notes are not going to document your homebound status. Most of those hospital discharge summaries don't tell you about homebound status. It doesn't say what's the medical necessity for the services for home health. It's very rare to see on an encounter note, skilled nurse for home health needed for medication management and wound care to the pressure ulcer of the left buttock. Physical therapy required due to gait abnormalities requiring gait training and transfer training. You just don't see that type of documentation on an actual clinical note. So that's why we go forward and we say it's a two-part documentation requirement. The actual clinical note, and then you have the secondary documentation to document the date of the encounter, the medical necessity of skilled services, and the homebound status of the patient. So how do we get that? How do we meet that second part of the documentation? Well, we can do that by combining or merging information that the agency has collected during their comprehensive assessment, and that can be incorporated into the physician's medical record. The way we do that is by that following physician signing off on certain statements, and then that 485 or that plan of care then becomes part of the medical record. Therefore, that agency information is incorporated into the record. Okay, so that information has to be corroborated by other medical record entries. What that means is if within your documentation from the agency you say the patient is wheelchair bound, but then you have a physician visit note saying the patient is ambulatory with a cane, they don't mesh, they don't match. They have to be corroborated. And in addition, the documentation of the face-to-face encounter must be a separate and distinct section of the certification. So the certification is your plan of care, okay? So if you're adding documentation to that plan of care, you have to show that as a separate and distinct section of that certification. So we're going to take a quick look of what that looks like and how you can make that appear distinct and what I mean by that. So this is an example of a plan of care home health certification and plan of care. This is the typical outline that we generally see. Box 26 here is where you see your certification statement. So this is what your following physician is certifying. They are verifying that the patient is confined to his or her home, needs intermittent skilled care, and that they have authorized services under this plan of care. Here's where we are adding in our agency acquired information. So this is assessment data collected by the agency that we are incorporating into the plan of care that the physician is certifying or verifying. You can see here, separate and distinct. We have clearly labeled this is a face-to-face encounter. I'm going to get my little red pointy here. So you can see here, separate and distinct. It's a face-to-face encounter. Okay. Second thing, we are documenting the date of the encounter on here. Date of the encounter. On this type of template, we've added in who performed the encounter. Now, the reason we did this is because this physician is not our certifying physician. That is not the physician that is signing our plan of care. So in order for us to show who did that, we are putting in their name. So we are documenting the date of the encounter and the physician that performed this. This has to match with the face-to-face encounter document. So I have an example here of, let me clear that drawing off there. So this is an example of an H&P we received from a hospitalist. So the date of service was 5/29. This is the physician that performed it. These were the reasons, the chief complaints, past history. I can look even further and see I got a med list here, but I'm also looking for proof of a face-to-face. So here's an objective assessment, shows that the physician actually saw that patient. And so that is the information that I am then putting into my face-to-face statement on my 485. The date of the encounter, the physician that performed it. So again, you can incorporate that into your 485. Now, we also have to document the reasons that the patient needs services. So we have to show justification for the referral for Medicare home health services. This includes documenting the medical necessity for all the skilled services ordered and the homebound status. So I'm going to go back here and look again at my 485. You can see here that this template we've used has medical necessity statements for each of the services that we're going to be providing. It also has a homebound statement. Now, when you're looking at your homebound statement, we're going to talk about that a little bit more in detail, but you need to make sure that you get specific. It can't just be that it's a taxing effort. Most of the EMRs will pull in these generic statements, and that's great, but CMS and all of the MAC auditors require more detail. So why is it a taxing effort? Why is the patient unable to safely leave the home? What is it that's restricting them? Medical necessity statements. The big thing to ask yourself here is, why is this discipline needed and why now? What has changed? What's new? How's the treatment changed? Is there a new diagnosis? Is there an exacerbated diagnosis? Why is it that this patient needs these services at this point in their disease process? You can have a chronic COPD and CMS is going to say, well, they don't need nursing. They've had COPD for 10 years. Why do they need it now? Your medical necessity statements need to show why now. So, specific statements. These here, pretty generic. I don't know that I would actually approve these to go through to an auditor. I should see, more information. Skilled nurses required for assessment instruction on diagnosed CVA disease process to include home safety precautions, to ensure, safe medication management. What is it that the nursing is doing and why now? Due to recent behavioral changes, due to recent cognitive changes, what within that CVA disease process has led us to need skilled nursing? Physical therapy is required to restore and or maintain physical functioning due to diagnosed right hemiplegia post-CVA. Okay, so we have a little bit more of an understanding, that patient has right hemiplegia related to the CVA, but I would say take it even further, that right hemiplegia resulting in gait abnormalities, resulting in repeated falls, resulting in, poor balance. What is the result of that? So really dig in and answer the question, why now? All right, so we talked about the need for skilled care. Let's move on. Homebound status. I'm going to dig in a little bit more deeper to homebound status here with you guys, because I want to make sure that we're assessing this appropriately, and this is information to make sure we are passing on to your field staff out in the field. So in order to be considered homebound, what does confined to the home mean? Number one, you have to meet one of these first criteria. So because of illness or injury, the patient requires a supportive device, or they require the assistance of another person to leave the home. Or the patient has a condition that leaving their home is medically contraindicated. Now, I have to say that's probably pretty rare to have a medically contraindicated reason for not leaving the home. So, I can think of, immunocompromised patients that may have that, but for the most part, most of your patients are going to be meeting this under the first requirement. So you meet one of the first requirements, you have to meet both of the second. So there has to exist a normal inability to leave the home, and leaving the home must require a considerable and taxing effort. What does that mean? What is a normal inability to leave the home, and what is a taxing effort? So a normal inability to leave the home means that leaving the home is infrequent, and it is for periods of relatively short duration. That is the definition they give us for a normal inability to leave the home. The CMS also provides us with some acceptable reasons. So those are listed here. So, being homebound doesn't mean they never leave the home. Being homebound doesn't mean that they don't drive. Okay, being homebound means that there's a normal inability, meaning that the patient leaves the home infrequently and for periods of relatively short duration, as well as there being documentation of it being a taxing effort. So I'm going to go into a little bit more homebound assessments to really show the taxing effort. Number one, you have to consider the safety. Does not matter what the patient is doing, what they've been doing, what they are doing. What matters is what they're safe to do. What is your recommendation to ensure safety? So you need to make sure that there's documentation of all assistive devices required, how much hands-on assistance is needed, and considering, if the patient has to go up and down steps or stairs. Look at, can they transfer out of the bed by themselves? If they require assistance to get in and out of bed, then they can't leave the home without hands-on assistance. Do they have vision impairments? Are they legally blind? How does that impair their ability to safely leave the home? What's the impact on their health? Does they require hours of rest upon return? What's their endurance level? When we talk about endurance, really get specific. How many feet do they walk before they have to rest? What is their oxygen saturation dip to after so many feet? Does it take an extended amount of time to prepare to leave? Does it take them an hour to get on their shoes and socks? Do they have to take frequent rest periods with, getting ready to leave? Are they noticeably short of breath? Are they short of breath, brushing their teeth, brushing their hair? Are they short of breath when they're walking or transferring? Do they require oxygen? Do they have to take extra pain medication before they leave the home due to increased pain when they leave? What's their cognitive functioning? Do they have a diagnosis of dementia or cognitive late effects that impact their ability to leave the home alone? Is there confusion, impaired decision making, disorientation? How does that impact their ability to leave the home? Does it mean they require assistance due to these limitations? Do they require special transportation? Do they have to have a wheelchair accessible vehicle? Do they have to take portable oxygen tanks? And if so, do they require assistance with, transporting this equipment? Those are all of the types of things we should see documented within your OASIS that can then be pulled into that 485 statement to justify and to stress and to show justification of their homebound status. All right, so again, we kind of looked at, the actual clinical note. So some things to look at when you're looking at the actual encounter note. I had one pull up here. This is one of the handouts that you guys got as far as an example that you may see. So these are things you need to pull out. Who's the physician performing it? Are they an allowed provider? Is it an inpatient physician? Is it a specialist? Is it the following physician? You have to identify who's performing this visit and if they are an allowed provider. Refer back to that slide on who is an allowed provider. What's the date of the encounter? Is it 90 days before or 30 days after? Does that meet the requirement? The examples that we get on these progress notes, I have to say are a little bit comical because we just don't see this type of documentation coming, at least where I'm from, on our progress notes. So, this has great documentation and we would love to see a physician say PT is needed to restore ability to walk. It just doesn't happen. So I seriously doubt you're going to see this type of information. What you're really pulling out of this note is it an allowed provider? Is the date within the allowed time frame? Does the reason for the home health episode match the encounter visit note? Is their assessment of the same thing that we're treating? Finally, one thing to pay close attention to, is it signed? Is it signed and dated? Is there an electronic signature? Does it meet the requirements of your electronic signature policy for the agency? So make sure and take a look at this. Some of these examples kind of walks you through what you're going to see. I kind of showed you an encounter note that I pulled and deleted a bunch of, HIPAA stuff, but this encounter note, just to show you, this definitely was not a perfect example. It missed a lot of the things that we needed, but I was able to see it was a hospitalist. the date of the service, excuse me, the physician that performed it, what the reason for the visit was. I kind of got a, past medical history here. I'm coming down, I can see that there's an objective assessment. I look to see, what that physician was noticing and treating during that assessment. Here you can see, facial droop, right-sided weakness. These are things that were assessed during this encounter. What's the impression? What's the actual assessment and plan? And then, that I've got a good signature. So is it an allowed provider? Is it within the time frame allowed? And is the visit related to the reason the patient is on home health? Those are the things you need to be looking for on that clinical note. Has to contain that valid signature and date. I included just some examples of some of the different types of documentation you may see. So ways to, complete that requirement, kind of like we talked about, it's very rare to see homebound status and medical necessity for the different services of home health on your actual encounter. So you meet that requirement one of two ways. You can put it on your certification, which is your 485, or you can send a separate signed addendum. Now, CMS, specifically CGS, has come out and said they really don't recommend using those addendums anymore. They would rather see the information placed on the certification, which is your 485. So kind of included on this slide, ways to meet that requirement if you're using the 485 or if you're using the addendum. Now again, just remember, what you have to see on that 485. You have to see the date. You have to see the physician that performed. I say you have to, you don't have to, you just have to see the date. But we'd like to see, that the doctor, the certifying, the following physician confirms who performed that face-to-face encounter. The medical necessity for all of the disciplines that are ordered for home health and their homebound status. So those things are listed out here. So you combine that signed 485 with your encounter note that meets these criteria, and you have a face-to-face requirement. This uses the addendum form, excuse me, just to show you kind of what that addendum form looks like. I have one here, and this is a reason they usually tell you not to use them anymore because they're never filled out correctly, even when we do send them. But this is kind of what it looks like on the addendum form, but you can see nothing's filled out, so that wouldn't meet our requirement. All right, so I've included on this slide the certification statement that was used in that 485 example. Make sure if you're using the addendum that you meet these things, and then really look at your EMR for what kind of forms that they have that you could send. And then finally, I included some common reasons for denials that we see most often. Whether the encounter was not related to the primary reason for home care, that's a very common one. How the patient's condition supports homebound status, so there was lack of details regarding homebound status documented. How the condition supports the need for skilled services. So you can't just say skilled nursing for CVA or PT needed for hemiplegia. Have to provide a little bit more than just a listed diagnosis. The date of the encounter missing. So remember we said on that 485, very important that you put in the date. The following physician has to verify the date of the encounter. And then finally, information contained in the certification does not match the encounter note. So again, very important to look at all of your information. One of the best resources I found so far out there was included in your handouts. It's this home health review tool. Walks you through each step of reviewing not only your face-to-face, but your 485 certification statement, making sure that you meet all of the requirements of CMS in order to get paid for your services. So look through this. This is very helpful as well. One of the other handouts I gave you was this one here, face-to-face encounters for home health certification. A little bit harder to understand. It's not a really good flow, but does hit the high points. And then one that I can send to anybody that's interested is a new one that I created here. So this one kind of walks you through what you should be looking at, first in the process. What's your face-to-face process? First and foremost, identify if your patient was discharged from an inpatient facility. If the patient was referred from a following physician that will be signing the plan of care, kind of takes you through those steps. So discharge from facility takes you through this one. Referred from a following physician takes you through this one. Referred by a specialist who'll not be signing the plan of care takes you through this one. Really, really pay close attention to those specialists that are referring patients to you, because you have to remember that their encounter visits will not meet the requirement. That patient has to get in to be seen by the following physician. Then it takes you to review the encounter note, make sure it's an allowed time frame, an allowed provider, and related to the reasons for home health. And then finally, making sure that you're pulling in the template to show that the following physician has verified the date of the encounter, the medical necessity for all disciplines, and the homebound reasons. So this is an additional process that I can send out to anybody that has interest in it. I think that is all I have. I hope that provided a little bit of a better overview of what we're looking for and what the auditors are looking for in order to meeting that face-to-face requirement. Again, please feel free to reach out with any questions. I'm always here to answer anything that comes up. Thank you.